Hi, everyone, and welcome to our first joint Trainee Hub event hosted by the University of Toronto's Edwin S.H. Leong Centre for Healthy Children and the UBC Edwin S.H. Leong Centre for Healthy Aging. My name is Priscilla Medeiros, and I'm the Knowledge Mobilization and Community Engagement Specialist at the Edwin S.H. Leong Centre for Healthy Children, and it is absolutely my pleasure to open and co-moderate today's session. I'd like to first acknowledge that we at the Edwin S.H. Leong Centre for Healthy Children are located on the traditional territories of the Huron-Wendat, Seneca, and Mississaugas of the Credit. We recognize and honor the Indigenous peoples who have cared for this land for thousands of years, and today this land remains a vibrant meeting place for many Indigenous people from across Turtle Island. From coast to coast, I acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Today, we will be discussing the ethical considerations for collaborating with patient and community partners in research, focusing on the critical first steps in building meaningful and equitable partnerships. By establishing these relationships, it does take time, effort, and trust. And the community-based participatory research approach can really help address those power imbalances, but it requires us to engage in real and sometimes uncomfortable conversations. It's more about the collaboration piece. It's also about shared decision-making, mutual respect, and being willing to think critically about our roles as researchers. And as we explore these concepts today, I encourage you to reflect on how we can foster those transparent, inclusive, and ethical partnerships that benefit both the community and the research process. I'm now going to pass it over to Kim Schmidt, who's the research director of the UBC Leong Centre, who's also our second moderator for today's session, to introduce to you our first panel speaker.
Thank you, Priscilla. Yeah, it's my pleasure to be co-moderating this event today. Before we get started with, introducing the first panelist, I just wanted to remind everybody to please save their questions for the end after all of the panelists have presented. If you have questions you would like to type into the chat throughout, please do so. But if you would like to unmute yourself and ask a question, then just save that for the end. So our first panelist is Dr. Ambreen Sayani, who is a physician and social scientist at the Women's College Hospital and an assistant professor at the Institute of Health Policy, Management and Evaluation at the University of Toronto. Dr. Sayani's areas of expertise are patient engagement, health policy, and cancer care with an equity lens. Dr. Sayani, turn it over to you if you don't mind sharing your screen.
Yeah, thank you so much, Priscilla and Kim, and welcome everyone to what is likely going to be a very interesting conversation once we're done with our presentations. So I am sharing screen and okay. Is that good, Priscilla? It's up. Alrighty. So I was asked today to really focus on the concept of power. And, you know, traditionally we're going to set ourselves up with three overarching objectives. And I thought, you know what, Michel Foucault does such an excellent job with this quote. And this is what I'm going to do in the next 20 minutes or so. It is to show you how power in its invisible nature just perpetuates the inequities and the marginalizations that we have in our society. And what does that mean for us as community-based researchers or people trying to build trust and relationships with communities? I'm going to start by situating myself. You've heard a little bit of my professional introduction. I will encourage you to think structurally with me, and I will share some of our co-created tools and resources through Impact. So let's get started. For myself, I live in the city of Mississauga. Mississauga for thousands of years has been the traditional land for the Huron-Wendat, the Seneca, the Mississaugas of the Credit. And I'm raising my family here. We live, work, and play, and I work from home. You see my home office. But I'm also part of a second-generation South Asian diaspora. And the legacies of colonial violence in the region of India, which was self-governed for the longest of times, and the the generational trauma that has happened through the partition of the Indo-Pak region, I think, is something that has permeated throughout my family. We're very conscious of the fact that social and cultural inequities persist across the diaspora. You will see people like me of South Asian descent, but we're spread all across the socioeconomic spectrum. And it's how many of us have lost our cultural identity, our heritage, our narratives have been lost. And you see us in all shapes and forms trying to make do with where we are in society today. I wear many hats. I'm a physician, I'm a social scientist, I'm a policymaker, but I think what really runs through as the current here is a desire to be a strong advocate through all those hats for fairness and justice. It won't surprise you then that as a critical social scientist, I know and I fundamentally believe that power relations are embedded in social and historical relations, and that there is no objective truth. You need to look back to history to understand where we are today. I also know that dialogue and discourse are so strong because which discourse comes forward and which discourse gets hidden. The status quo maintains the different ways in which oppression occurs. And unless we look at it in the face and challenge it, we really won't understand its shape and form, and therefore we cannot contest with it or even create a different society. So welcome to my lab. What do? I focus on cancer care because of my own clinical training. But fundamentally, what I'm out to do is to address structural inequities as they're experienced in healthcare, in policymaking, and the focus of today's talk, which is really about those partnerships that we develop with people. So what does it even mean to think structurally, right? We say it, and I think we're increasingly throwing it around so often. Let's look back at some of these fundamental definitions. What is social location? Social location is a rank order. All of us have a rank order in society, whether we acknowledge and accept it or not. And this rank order is determined by the different degrees of power, privilege, and access to resources that we have. Based on the clustering of those resources, people get grouped. And they get grouped in different ways so that they stand as clusters or different social classes. When we create policies and systems without involving people, and we continue to perpetuate those same policies and systems that created those social classes so that they are everyday acts of being, we kind of entrench these things into society because they've become so pervasive that we don't even see them anymore. And this is what it means to have structured social inequity. It's just there, but we don't understand how or why. We can't put our finger on the thing. It's such a wicked problem because we don't even know where to start. And I'm going to throw a couple of quotes at you today, 3 in total. This is the second one. I love the work of Paulo Freire, and he says it so well. When you alienate human beings from decisions that impact their own life, they become objects. And this is what we've started to do, even in a well-intentioned way. We objectify and we otherize people. Oh, they are the group that needs. But that's fundamentally not a strengths-based way to look at it. Communities are resilient. They understand their needs. They know their priorities. It's just about us creating the resources and the mechanisms for them to take leadership in decision-making to advance their own goals. What does patient and community engagement have to do with it at all? Almost all of us have been in this structure of engagement where we have a project grant, we got $10,000, or we have 6 months to engage with people. We have a healthcare project, which either myself or perhaps myself with a handful of patient partners think is super exciting. So we set out to do it. But these are the structures within which this is often happening. The healthcare system is not always one of comfort for people who've experienced discrimination and trauma. Not everyone has access to these spaces because of the ways in which they live, work, and play. And so therefore, the question is, who are we really bringing into these spaces to design care or to design policies, and who's being left out so that we are objectifying them and we are making them kind of like the byproducts of decisions that we've taken, but in doing so can perpetuate health inequities. This is what our landscape looks like in Toronto, and I know people are calling in from different places. But almost half of our population speaks languages other than English and French. They're born outside Canada. We have such a variety of intersectional identities that are just not making it into institutional patient engagement. And there was a Canadian patient partner survey that was released last year, in which I think over 80 to 85% of patient partners are identified as women who are white and well-resourced and able to volunteer. So why is it that we have this discrepancy? And even when we do pull in people into those rooms, which parts of their identity are they allowed to bring in because it is of relevance? Who decides what's of relevance? And what are we asking people to leave at the door because it's just not so important to the discussion right now? It may be important to you, but it's not important to the discussion if you're going to be at this round table. So this is how power permeates. What is power? Power is the ability of a person to act, to take a decision. It's mediated through social relations. It's legitimized through language and policies, the way in which we produce knowledge. Power over is the asymmetric relation between two or more people so that they can influence each other. Power to is the ability to produce an outcome of relevance. And power with is the collective. Have I been muted?
You're okay.
Yeah. Okay. Is the collective mobilization of a group of people towards a common goal. So what does this have to do with impact? And I'm just going to take a slight detour to talk to you about impact, but I encourage you to look up our website, and there are other tools and resources to learn more. As a group of people, we came together and we're like, current systems aren't working. If we have a clean slate and we want to imagine what it would look like to bring in people who've never been involved in decision making before, let's think up of something new that works for all of us. And that's what impact is. It is a patient engagement model that centers the perspectives of diverse communities and drives equity promoting decision making in health and social care. Fundamentally, what everybody agreed on was there need to be pathways to change. Unless you're connecting people to possibilities of change, every interaction is tokenistic. Secondly, there is power in numbers. So what impact did is it flipped the power dynamic. So instead of one or two patient partners sitting at the healthcare table, impact is a community, and people from the health and social system request a seat at the impact table. So there is power in numbers, and the power is flipped because people on the community table decide who is allowed at their table, whose project is of relevance, and who do they want to partner with. I won't get into this again. I encourage you to look into impact in detail, but it's a very process-driven methodology to drive power back to communities and away from those who've currently been holding them in ways that are inequitable. We've been quite successful, so it hasn't just been a model that we've tried. We've actually been able to shift power for decision-making across a variety of projects, all the way up to national level agencies. But then we didn't want to stop there. We're like, okay, if we're doing this so well, how can we help other people think about this? And so that's when the group came about and co-created a new tool. As you can see, there are many patient partners in this group with over 30 years of collective experience. We drew on Gaventa's conceptualization of the power cube and came up with what is known as the power wheel. And this is the resource that I'm going to share with you. Feel free to use the QR code, go into the website, play around with the power wheel. This conceptual model was co-designed by community with a graphic designer, and then we worked with the web designer to make it an interactive tool online. So you can actually go and click and play around, create your own wheel, download it, upload it, whatever you'd like to do. There are 3 dimensions in the power wheel, and each dimension has different levels. Let's take it one by one. The first dimension is place. What is place? Place is the area that is open to decision making. And it can be at the macro level, so it's national level policy, for example. It can be at the meso level, so it's an institutional project, but patient partners are involved in guiding how the institutional policies or frameworks around patient engagement, for example, may be happening. Or it may be a micro level project, which is let's change the design of this brochure so that it's more accessible or meaningful to patient partners. So really the ways in which people can be involved varies. These places hold different degrees of power based on where they can create change. The next is space. Space depends on the social relationship between groups of people. In closed spaces, patient and community partners are not invited. Very often, they don't even know that these decisions are happening about them. What happens most often is that patient partner community perspectives are solicited. So people are invited into a project. I have a project, it's been funded. I'm really excited to work with you. Do you want to grab a coffee? Let's have a conversation. Would you like to join my advisory board? And, I welcome your perspectives on my work. Fundamentally, however, it's an invited space. Created spaces are those where patient partners and community members come together themselves. They've coalesced around a shared agenda. And this is where they create priorities around their needs and goals. And then the last is influence. So patient partners can be told about information. We can ask them for their feedback. We can work together to come up with outcomes, or we can put them in the driver's seat and say, you know what, you tell us what is really needed and we'll go from there. When you put them all together, they take the shape of the power wheel. And you can pick and choose when you go to the interactive tool and see which level, which dimension in terms of place is my project working on, which dimension in terms of space, and how about influence. A key goal of creating this power wheel tool was to enable reporting of power dynamics in patient and community engagement. As I said earlier, power is invisible, and that's how it wields strength and maintains the status quo. So one of the most important steps is to make it visible, and we can all do that through reporting. Once we report on these spaces, places, and degrees of influence, we can reflect on what's happening. So why is it that so many projects that are patient and community partnered are actually only, and I'm giving an example, are only at the meso space? Why are they all always invited spaces? And why is it that we're most often just consulting with people? These are questions we can ask ourselves as a group and think about what needs to change to drive power back to communities. This is an example of the power wheel for MPACT, and MPACT is a patient partner community group. So as I mentioned earlier, they decide who gets a seat at their table. It's been created and has been pretty successful in actually influencing national level policy. Other times, people will come and ask for collaboration on a project. So it works in different ways, but because it's a created group, it wields a different kind of power. This is probably one that's most common, which, as I had mentioned, is a micro level project. It's very focused on a specific outcome. People are invited, and very often they consult. I would not say that there's anything wrong with this power wheel. I don't think there's any type of wrong patient and community engagement unless it's harmful. I think all of it is important. But what is more important from a health equity and justice lens is to be able to reflect on who's included and who's missing from these spaces and which power dynamics are at play that are either including or excluding people. And then fundamentally, what are the implications of that exclusion on our society and on the health gap for all people? So in closing, I'm going to leave you with another quote from Michel Foucault that knowledge and power go hand in hand. We've gone from invisible power dynamics to talking about a tool that enables us to contest and make visible the issues that are pervasive in spaces of patient and community engagement. Once we make it visible, it becomes a knowledge field in itself, and that allows us to grapple with it in different ways. When it comes to impact, what we did fundamentally was not try to shift the needle a little bit at a time, because incremental innovation is good, but sometimes you just need to do things completely differently in order to succeed. And this is what we've done with impact. We've worked on growing relationships of trust. We've listened and learned together. We've worked really hard to share power and push it back to communities, created processes of change so that the conversations are about things that center the needs and priorities of community. And because we've done this across multiple different projects, from local, regional to national, we're building a health equity movement, which was really the goal of impact to begin with. Again, I encourage you to check out our website. And I'd like to acknowledge Women's College Hospital, CIHR, and the Ontario Sports Support Unit for their generous funding and support to do this work. And with that, I'll pass it over to my colleagues.
Excellent. Thank you so much, Dr. Sayani. That was really informative and wonderful presentation. So next, our presentation will have two co-presenters. First, we have Dr. Susitha Wanigaratne, who is a senior research associate at the Edwin S.H. Leong Centre for Healthy Children at the SickKids Research Institute, a fellow at ICES, and an adjunct lecturer at the Dalla Lana School of Public Health. Dr. Wanigaratne is a social epidemiologist whose work examines immigration as a structural and social determinant of health. And our co-presenter will be Dr. Manveer Bagnu, who is the founder of Ladlia, which is a nonprofit that aims to empower South Asian daughters through education, engagement, and awareness. Ladlia has directly impacted over 12,000 girls and women through mentorship opportunities, access to menstrual hygiene, bridging intergenerational divides, and much more. So I'll turn it over to the two of you.
Thank you so much, Kim. Just to clarify, I'm not a doctor. Although I'm sure my parents wish I was, I'm not. Just kidding. So hi, everyone. Happy to be here. I'm Manveer along with Susitha, presenting for God knows how, whichever time we're doing this. We've been presenting about our work over the last several years and are very proud of what we've accomplished together and hope to give you some great insights around that today. I'll pass it over to Susitha to get us started.
Great, thank you. I just want to wondering if my slides look okay. I know it just
okay.
Yeah,
it's good.
Okay, great, thanks. Thank you, Manveer and Ambreen. I really appreciated your comments and your presentation on power. And I guess just to start, given my positionality in relation to the community that this project is about. I want to say that I'm a second generation Canadian of Sri Lankan origins. In addition to the professional identities I have that you heard Kim speak to about, I have many others. And I think in relation to my family, I'm a wife, a mother of two great little kids. I have nieces and nephews, and I'm also a sister, daughter. So I have many other identities as well, but those are all very important to me. And as always, I'm always grateful to present alongside Manveer. We're going to be walking through our work together that started around in 2017. And it hopefully we think is a very useful example in meaningful partnership. And it started in a community-based participatory research project. So just moving on to my second slide here. Okay. So what brought us together? The initial project that kind of predates the work that Manveer and I started together was in 2012. So there's a series of papers using mostly ICS data, but also Statistics Canada data, beginning, as I said, in 2012. And I think the latest one was published in 2018, which I'll come to in a bit. But really, these studies examined sex ratios among immigrants, mainly in Ontario. And generally, the main point from all of these studies is essentially that they found sun-biased sex ratios. that were most strongly among people, mothers that were born in India and after the birth of two females, that sex ratio, so the ratio of males to females was quite biased towards sons. So that's the basic picture. And the three studies from 2016 and 2017 were community partnered projects. They were with Punjabi Community Health Services and South Asian Women's Centre. And I was a postdoc and a co-author on two of these papers. So that's kind of my entry into, thinking about this work. And these were under the leadership of Marcelo Urquia, who's now at the University of Manitoba. So just to kind of back up and talk about, why these studies were done, essentially, similar biased sex ratios were found in India and China. And essentially the question that was posed was, do sex ratios occur in diaspora communities in Canada? And, the studies that I just described previously demonstrate that they do exist here as well. So in terms of a definition of what son preference is, it's essentially the attitude based on the belief that girls are inferior to boys. And I just want to be clear that sex-selective abortion that favors sons is a really extreme form of son preference and gender-based discrimination. There are other ways this manifests in, communities and different communities, not just South Asian ones. But, sex-selective abortion is kind of the outcome that we examined with administrative data. But there's a spectrum there. And then I guess the larger effect of son preference is really that it limits the health, educational, social, and economic opportunities and potential of girls and women. So also just to take a step back and, describe why, we think community engagement, particularly in health equity research, is really important. So what often happens in research in minoritized communities, this happens, in the literature, but also like in public discourse, is that minoritized communities often get blamed for poor health behaviors, for poor health, and it's framed as an individual responsibility. And this really ignores the structural and the social determinants of health. And community engagement and research really enables a more meaningful and more accurate understanding of the problem. It can point to more appropriate and effective and acceptable ways to move forward. And I think the ultimate goal with community engagement and health equity research in particular is really to transform systems that cause inequities. And I'd say that community engagement is helpful, and if not a necessity, in this type of research. And hopefully I'll make that clear, towards the end of my part of this talk. So in terms of ethics in community engagement, I just put up, a few ideas around what ethical engagement looks like when you're doing research with communities. And I think it's, essentially definitely around sharing knowledge, sharing power, as Ambreen talked about, in relation to decision making, and that should happen between researchers and communities. We want to work to avoid tokenism and harm, and I think it's also ethical to work to synthesize knowledge and experience of all the partners, and really to create culturally competent, rigorous, relevant, and beneficial health and social services research interventions. So all the whole gamut there. And I think the work that Manveer and I did together, hits all these points of ethics. And I encourage you to think about these as I talk about the content of our work together. So how our partnership started was a women's college funded grant, a really small community engaged grant that was put together by myself and others in 2017. And really what we were trying to do was, given this, a ton of quantitative information we had about son preference, son bias sex ratios particularly in Ontario, we didn't really fully appreciate, the complexity or the context of why it was happening. So we put together this grant. I was at St. Mike's doing a postdoc at the time, and again, these were partnered with PCHS as well as South Asian Women's Centre. And it was pitched as a community-based participatory research project. So just a few points around that is that it's a project in which community members participate in all aspects of the project equitably, and we co-developed the project together. So Manveer was introduced to me through my research coordinator at the time, Aliyah. They met on a separate, I think, at a separate focus group. So a small world. But Manveer, once we were introduced to each other, she really became a very integral and active member of the project's research staff. So just to show you like the depth of engagement that a CBPR project at least this one, that we formulated as. So really, as I said earlier, community members were engaged with all parts of the project. And Manveer, and I put up the Loudland symbol here, but it's really Manveer who was the representative that was involved with so much of this. We did consult early with organizational leaders and, to revisit the goals and the objectives we wrote out in the grant. But, once I was introduced to Manveer, she provided feedback on the facilitator guide that we initially put together, did so much translation work for us, led focus group discussions, took notes, reviewed our transcripts once we analyzed the results. And one of the main things that we wanted to do out of this particular project was to develop an educational info poster. And I still remember the meeting when I drove to Brampton and met with you, Manveer, and staff at PCHS around like what that info poster looks like, and we'll get to that in a bit as well. So in addition to that, Manveer's also been involved with 2 publications that we were working on, this one related to the qualitative work, but then also another, which I'll talk to you about in a bit as well. So in terms of that educational info poster, that was the goal of the project. Ultimately, the content of this came out of the focus groups that we did, and those focus groups were all in Punjabi. So I was sitting, in the back of the room, not really knowing what was going on. But I got the transcript afterwards, and we decided on the content of the educational info poster, and really we identified these misconceptions. We worked with a graphics designer. But then Manveer and others were really instrumental in making sure, we got the content right, that, the terminology we used made sense, the colors, the infographics, all of those things. And we also decided to translate it in Punjabi, which I'm pretty sure, Manveer, you were the translator for this info poster. And we also translated into Hindi. And so we printed these up, we gave them to community members. But then after that, a year or 2 passed before I really knew what was happening with them. And Manveer, I don't know if you want to jump in and describe how you use this in the community.
Sure. So thanks, Susitha. So we've been using it largely on this info poster quite extensively. We do a lot of community outreach, setting up community booths, going to various events, talking with community. So it's always on our table, making sure that people can either take it with them. We have physical printouts of it. Or they can chat with us about it. We've had lots of people that are very, grateful that we've actually been able to put something like this together. But then it also kind of
Is Manveer frozen?
to be able to make a case as well. So, sorry, did I freeze there?
You did, just for
Okay,
about 10 seconds.
I don't know where you all lost me, but I was just saying it's been really great for us to have a tangible item that we can, share with our community when people do counter the argument around son preference in our community. It's good to have something like this that we can share, and that's backed by research, which we can see, no, it is the case, because a lot of the times we find that in our community, people don't want to accept this issue of son preference or this, desire for sons over daughters. So it's been very helpful. We've shared it over, I would say, hundreds of times with community members, and it is also on our website and socials as well.
Thanks, Manveer. As I mentioned earlier, one of the products that came out of this particular qualitative research project was this paper that was just published last year, and I highlight our community members that were co-authors on this paper. I learned so much from the process. We developed a conceptual framework highlighting, the different structures that reinforce son preference. We reported findings from the qualitative study, as well as we were attempting to disseminate the info posters to a wider audience. So Manveer and others were co-authors and obviously instrumental in this particular project. I'll back up a little bit to the time in which and Manveer and I were probably like a year into our work together, and I was writing another paper using administrative data looking at son bias sex ratios amongst second generation South Asians. And, given, I was getting I really enjoyed working with Manveer and this other community member, Pamela Uppel, who they were so critical in forming how I, wrote the discussion. We invited them to be co-authors on this paper. And I'll just say, which was always shocking to me, the metrics of this paper was that last time I checked, it's been viewed over 125,000 times and downloaded, full downloads 3,000 times. And just for comparison, there's a Michael Marmot, who's like, the father of social inequality in the UK, had an editorial the same year. And those are the metrics, which are far lower than ours. So I'm like grateful that people are reading it. I don't know who it is, but it's pretty amazing, the metrics related to this paper. So given Manveer was a member of the community and had this nonprofit in its fledgling years, we really there's really not much point in me being the face of this paper. So we wanted Manveer to do the media engagement. She did really such a wonderful job. She was in the Toronto Star, Globe and Mail, just really spoke to this from the community perspective, which I think was really needed. Manveer, I don't know if you want to jump in to say anything on this slide as well.
Sure, yeah. So I think a lot of this work brought, again, a lot of media engagement for the organization and the work that we do and why it's important. So again, just a lot of credibility for us as an organization was provided. Although I will say I was very young at the time, and I don't think I knew necessarily, in terms of how much traction our organization might get or how many requests we might get from media. So I think there was a little bit of unpreparedness on my end or on the organization's end of just how to deal with all of this. But it was a great learning opportunity, and I think it did lead to a lot of other great things, which I will speak to in a little bit. But yeah, I think being on on a actual physical newspaper in the Globe and Mail and the Toronto Star was something very very critical for us as a very grassroots organization at the time.
And a learning for me, I think, is that in the future, I think I would try to, because it was new for me as well to be involved with media, but I think we should probably have had more conversations about, comfort level and maybe get the institution involved as well. So that's like a learning for us. And before I hand it off to Manveer, I just wanted to also, when we think about the structural determinants of health, and as researchers, we really want our research to, have a positive impact on policy. But strangely, and what was really surprising and shocking to me was that our research was actually used in a harmful way. So Pam and I were reached out to by an MP who I will not name, but we're essentially putting forward this bill to criminalize abortion providers in Canada. And it was basically centered around sex-selective abortion. But really, this bill is framed around criminalizing providers, which ultimately would reduce abortion services in the country and also really stigmatize South Asian women who seek services. So given that, this is not the way I wanted this research to be used, this was like, the MP didn't really have a consultation with us. She was going to put this forward anyway. I really felt it was like an ethical obligation for us as a group working with each other and as myself as a researcher that we address this. So Pam got us all together one Saturday morning and we came together and we were like, what do we do? We decided to write a policy brief. We distributed it on social media. We sent it, I think Manveer and others sent it to MPs. Really basically just, outlines the issue and why this is a really bad idea. Ultimately, it was defeated, which is great. I'm not saying that it was because of us, but really my point in all this is that we want to influence policy. We want to reduce inequities. We can try doing that at the policy level, but sometimes policymakers don't really have the best interests of community in mind. And I think that's why it's really important that we also work with community organizations, communities to get the right narrative out there and to try to push for something that's more equitable, which is really why I'm grateful that Manveer is able to do her work. In relation, we also did some advocacy around this, which I won't talk about as well, but it was really really motivated, a different part of me as a researcher. So my particular learnings from this were, that research is so critical, like community engaged research is so critical. I learned so much in the process to really fully understand the nature of the problem and what the acceptable steps are. And also communities always know what happens. Like there's no way that Manveer and others I spoke to didn't know that some preference was happening in the community. So how can researchers ensure that, communities benefit from the research process? It's a really long-term commitment. And, we took a lot of time and flexing of resources. And I think there's really an ethical obligation to address harm, which I described previously. And this relationship building that, that I have with Manveer and others really motivated a commitment to diverse kinds of action to reduce health inequities. And I have now personal investment in Laldian's success in achieving their mission. So I'll pass it off to Manveer.
Thank you so much, Susitha. So just in case you're all wondering, what is Ladlia? I wanted to start off by giving you a brief overview. The organization was founded as a Facebook page in 2013 in my living room. And all I knew was that I was starting to see stuff in the media and the news around son preference and this discrimination against daughters, which I personally grew up with as well. And I saw a lot in my own community, in my own extended family. So Ladlia was born out of that desire to do something. And essentially what Ladlia means is beloved daughters. There's no direct translation, but it was a name that was recommended by my mother, who has two daughters and has always treated us just as lovingly as she has treated her son. And who's also my brother. I don't know why I said it like that, but we were sitting there and I was telling her I want to do something, and that's how Ladlia came to be. At that point, I had no idea that it would become a nonprofit organization and we would do all this great work. I just knew I wanted to talk about the issues that I was seeing in the South Asian community. So the goal of the organization, or the mission of the organization, is to empower South Asian daughters of all ages through education, engagement, and awareness. And I think at the time when we were working with Susitha, we were very grassroots, like I mentioned, and have since grown a lot. And a lot of that can be, it is thanks to the partnership that we had early on with Susitha for this project. Next slide. So one of the biggest impacts that this partnership specifically had on our organization was a program that we launched in 2018 called BG and Me. And I think this was something that came out right away for me when we were having focus group discussions. And I was taking notes and I'm thinking, and I remember like sitting there and it was really hard to contain, myself when I was hearing women from my own community talk about how they view daughters and other girls and women. And I remember like it was very hard like to not cry or to not react. And as a researcher, as a research assistant, so I remember I wanted to like take that away and do something with that. And we said we would, and I didn't know how we were going to do it, but we started this project called BG Mom and Me. Now it's called BG Mom and Me, but at the time it was called BG and Me. And BG is a Punjabi term for grandmother. And it was essentially to eliminate a lot of these misconceptions or these beliefs and values that a lot of these senior women had around daughters. And we were finding that a lot of the discrimination and pressure that was coming, or that was around having daughters, or preferring sons over daughters, was coming from that generation of women, which was just unfortunate. And I really wanted to do something about that. So we designed this program to work with seniors, grandmothers, and granddaughters, to bring them together and to increase intergenerational understanding and lessen the communication gap. We found that there's so much that we can learn from our elders and vice versa, but we were finding that a lot of the times the expectations that these grandmothers placed on their granddaughters were unreasonable and just outdated, and we wanted to change that narrative. So we've been running the program since 2018. Obviously, it depends on funding, but it's been a great opportunity to bring different generations together and talk about why we view girls and women in a certain way, why we have this innate preference for sons as a community, and how, why are women the ones that are always cooking first and men get to eat, or cooking, but men get to eat first and women get to eat last. And just all of the things that sometimes grandmothers and moms are passing down to their daughters, which are, again, not necessarily very equitable or fair. And we've been able to do that through various activities such as painting, dancing, cooking together, having tea together, yoga, mental health workshops, and so forth. So we make it very fun and engaging, and have recently changed the program's name to BG Mom and Me, because we were getting a lot of requests from moms to be involved as well, because they felt that they should also be a part of this conversation. So that's been a really great program. We've engaged over 250 grandmas and granddaughters and counting. And it's one of those really, like, I feel like every time we have a session for BG and Me, I walk away with so much more love and affection for, for all that our grandmothers had to go through, and all of the reasons why they believe in what they believe in. So it's been a great learning for me as well. Next slide. Thank you. And other ways that Larnia has grown as well is, it's again, we've done so many great things as a result of this one partnership in 2017. We were asked by YWCA Canada to inform Canada's National Action Plan to End Gender-Based Violence, where we got to make sure that the South Asian voice was included in this plan. We, held focus groups, we presented recommendations, we shared ideas. And that was something, huge, because oftentimes our community voices are left outside of these national actions that are happening, or these national activities that are taking place. We've had academic publications, like Susitha mentioned, which I say we because I do consider myself synonymous to the organization, and I feel like a lot of the work that I've been a part of reflects the work that Larnia is doing and has been able to bring a lot to Larnia. So we were able to do, have some publications that again gave us a lot of credibility in the community and opened up, opportunities for more dialogue and discussion, which then led us to getting funding from Marcelo, actually, who was originally involved in the research that we did years ago, to host a conference, the first of its kind on gender equity in the South Asian diaspora earlier this year, which was so well attended. And it was a very community-focused conference. We tried not to make it, as an academic conference. It was, again, it was in the community. It was literally hosted in a community center. And it was just it was such an amazing moment to just see all of the people that we've been able to bring together, to different discussions, different nuances. And I can tell you that one day was not enough to have all the conversations that we needed to have. And it's been particularly even, more amazing to have Susitha involved in all of these projects as a mentor now, which has been a blessing as well, because it's really hard to find mentorship, I feel like, as a racialized woman, when, especially from a cultural nuance, which Susitha completely has understood and has supported in so many ways. Next slide. So needless to say, our friendship, I'll say our relationship didn't end. We actually have a great friendship now as a result of our initial partnership, and continue to work together and bounce ideas off of each other. We're constantly meeting up, emailing each other, seeing if we can do anything else. We're always presenting this research. We've done a lot of presentations at various universities, at various other institutions where we can share our work and what worked so well for us in terms of our collaboration. And then I'm always sharing what Larnia is up to with Susitha as well, which again gets her to be creative and see how she can support us. So currently, we're working on a scoping review on health outcomes of international students. Larnia has been doing a lot of stuff, a lot of work on the employment exploitation of young women international students who are South Asian. And I've been able to engage Susitha in supporting us with some of that work. And we're hoping to launch, we will be launching the first ever South Asian Women's Health Conference next year in partnership with South Asian Tamil Women's Collective. And again, Susitha is on board as a mentor for that as well. And we are constantly looking for other ways to work together and sharing, even opening up doors for each other that the other might not know about. Susitha has sent me lots of funding opportunities, which I didn't know about. And we've been successful at securing that funding. And that's really helped us build our capacity as a small organization. Thank you. So in terms of why our partnership works, I mean, it's always been great working with Susitha. We've never had any friction. I think Susitha really created a lot of room for respect and understanding right from the beginning. I was very young. I'm going to be very honest. Like, I don't even know what I was doing, saying I'm going to take on this work at that age. But it was just something that was, Susitha never made me feel like, oh, you're too young, which is something that can really happen if you're a young brown woman trying to work in a space like this. People can really make you feel, less than. And I never felt that. So there was a lot of respect and understanding. We're both very community centered, and I've really appreciated any opportunity to be able to represent the community in the most genuine way that I can. And it's never been it's never been about credit, or it's never been about, oh, I want to do the speaking in public, or I want to get the credit for this. It's really been, this is about the community, what's best for the community. Like I said, we continue to share networks and opportunities with each other, and really do give each other the recognition and credit that is deserved. And we have a mutual interest and benefit, and now I would say even a friendship, where we want to see each other succeed and want to support each other's work and goals. So it's been really lovely. And I know this is not your, traditional partnership when we think about academic and community partnerships, but I really do think there is this other way of doing it, and it is really beneficial, not just to the community, but also to everyone involved. And even our whole team knows of Susitha and is in awe of everything that she does for us and supports us. And I would say is an honorary Ladlia member herself. So those are just some of the ways in why our partnership has worked for so many years.
Thank you. Right. I think maybe I don't think we need to go through this slide, Manveer. Maybe we'll just end it because we're a little bit over time.
Sure. Yeah.
Okay. Thank you.
Sorry, everyone. We're both talkers. So
No, that was great. Thank you so much to both of you for sharing your experience. That was really fascinating. Our final panelist today will be Dr. Annalyn Conklin, who's a social nutritional epidemiologist and associate professor in the Faculty of Pharmaceutical Sciences at the University of British Columbia, with expertise in epidemiology and outcomes research. Dr. Conklin's lab examines how broader social determinants, such as social ties or economic stress, impact cardiometabolic risk factors differentially for older women and older men. So Annalyn, I will turn it over to you.
Thank you so much. And thanks to the other speakers for starting us off in a good way. I'm just going to share my slide and hopefully you can see my screen. Are you able to see? Yeah, okay. I'm seeing some nods. Fantastic. So I'm going to focus specifically on ethical considerations for engaging with Indigenous communities as partners in research. And so before I do that, it's good practice to, position yourself with respect to the land. So I'm calling into you today, zooming into you today from what's called Yalmouth territory. And Yalmouth is also known as Jericho Beach in Vancouver. And it is the territory of the Musqueam people, the Squamish people, and the Tsleil-Waututh people. So they are Coast Salish First Nations. And why that matters to me is because I come from Southwestern Ontario, and I've traveled around the world for my graduate education. And it was a long time that I was away from Turtle Island. And when I came back, I was really grateful to be in the most beautiful place that I think is on Turtle Island, which is the West Coast and the Coast Salish territory. So I'm first going to start off with a perspective that comes from the Anishinaabe on the eastern side of Turtle Island. And it's called the Seven Grandfather Teachings. And I want to offer this as an Indigenous way of knowing that can help set the scene and contrast with our more standard ethical frameworks that we use in kind of Western science. And that hopefully will transition to the guidance that we have today that tries to acknowledge some of the alternative perspectives that exist in Indigenous communities. Of course, there is diversity, but there are some general commonalities that are quite distinct and unique. And then I'm going to talk a little bit about how to develop trust as a way, as the foundation for being able to engage with Indigenous people, and then give you an example from the research I've done about how did I actually go about doing that? How did I try to implement some of that kind of more broad, general guidance that is quite vague and hard to always understand what it means? So there's a number of different kind of images or pictures that reflect the Seven Grandfather Teachings. And those are principles that came about as to give guidance to Anishinaabe or Ojibwe people on how to live well and how to live well in relation to others. So there's about 7 principles or concepts. There's the use of good sense, which is referred to as wisdom. There is truth, which is about being faithful in reality. There's treating others in all life equally. So humility is the word that's reflected in that. And then there's the practice of absolute kindness. So the idea of love, or the word for love, which is quite unique. We don't have that in our 4 principles of bioethics. There's also the idea of bravery, or, using courage to choose. Because when we make choices, we often need that courage to act, to make a choice. And then also acting without harm, which is common. We have the idea of non-maleficence in bioethics or research ethics, and that's reflected in the word for respect. And then finally, truth-telling, so telling the truth, which is honesty. So several of those values, those ethical values, are similar in bioethics frameworks, but there's a number that are quite unique and distinct and important for trying to understand the process and the good way of being when you're a researcher engaging with Indigenous communities. So formally in Canada, we have the Tri-Council, which is NSERC, SSHRC, and CIHR, and together they have a policy statement that any researcher has to go through and get an ethics certificate. And there's a specific chapter dedicated to how to involve Indigenous communities. And it's really just general, broad guidance on how to start an ethical dialogue between researchers and Indigenous communities. And it really focuses on the idea of respectful relationships, and that to have respectful relationships, you need reciprocity and you need trust, and that needs to be built over time. So what does that mean in terms of our kind of more general framework of respect for persons, which is the first principle of our bioethics framework or research ethics framework? And this idea of respect for persons in the context of Indigenous communities extends beyond the individual. So it means respecting the collective welfare and the rights of the community, not just the individual participant in your study. And the principle of justice that we have in our bioethics sort of toolbox also demands, in this context, community engagement. And we've heard a lot from the other speakers about community engagement. And that, of course, can be done and has to be done through relationships that are built on mutual trust. And it also involves joint decision-making of the research goals, of the choice of research, the methods, and also the level of engagement that community wants to have, right? So perhaps they do want to be in a more consultative capacity, and that is the choice of the Indigenous community, that they set that level, but they may want to be completely involved. And so the researcher has to adapt to that idea. And I would say that it's most desirable to be able to adhere to these guidance when you apply a collaborative participatory action research approach, because it ensures that mutual benefit, which is part of the demands of justice and respect for the collective person. So other considerations that are reflected in this tri-policy chapter is the respect for the Indigenous governing authorities. And that's not just the formal council and leaders, but it's also ensuring that you have an inclusion of diverse voices of people who maybe not in leadership positions within the community. And it especially involves respecting the customs and the protocols, which are often kinship-based and involving kinship networks, reflecting past and future ancestors, and understanding the idea of sacred knowledge, and that some sacred knowledge is not to be shared outside of the research space and cannot be included in any kind of outputs. And then, of course, recognizing the role of elders and knowledge holders. And ideally, again, for direct community benefit, that building that research capacity within the community itself. So in addition to that chapter of the TCPS, there's also some principles that were developed by First Nations groups called OCAP. OCAP stands for Ownership, Control, Access, and Possession, and it was established in '98 by the National Steering Committee of what is now known as the First Nations Regional Health Survey. And it was created because essentially there is no law or concept in Canadian legal frameworks that exist to recognize community rights and community interest in their own information. So the OCAP principles assert that First Nations do have control over their data in terms of the collection processes and how the information is stored, interpreted, used, and shared. And so it's really just a tool to ensure that is done, acknowledged, and part of the research process. And it's partly because of the past that obviously First Nations, or they use the term Aboriginal, and that's the historical term, but Indigenous groups were never consulted. And you have what's called helicopter research that's happened in the past, even up until fairly recent. And that information that was gathered may or may not be relevant to those community groups, and certainly never often shared back. So because of that problem in the past, and here are some really important examples, one related to UBC, in fact, involving Nuchawnath First Nation. Because of those historical examples, that was why this OCAP framework was developed. And I really encourage you to visit that training. There's an introduction to OCAP if you're interested to learn more about the history and what it means and what's involved in implementing OCAP. So, as I said, everything is premised on respectful relations and also the relevance of the work to the community. And that includes a sense of reciprocity for the community. So reciprocity of knowledge, reciprocity of power, reciprocity of assets and resources. And there's also responsibility. There's a responsibility on the part of the researcher to ensure that they respect customs, that they engage elders, and that all the information and processes and methods and research questions are all driven and led by the community. And all of that together builds that trust. And it takes time to build that trust. It doesn't just happen overnight. And each of these pieces are obviously interrelated to each other. And you start where you are and you do what you can, and you come from a specific viewpoint that I'll come to on the next slide. So the first step that I took before as a way to start my journey of Indigenous research, Indigenous health research, was I made a personal commitment. I made a personal commitment as a professional and just as a human in this space where I'm a guest, is to have a lifelong journey and to be in relation as the way that I do my research, the how that I do my research, that process. Everything I do is in relation. And it's informed by that lifelong learning journey of Indigenous traditions, different nations, the history, learning historically and contemporary. And that involves going to seminars, doing as much learning as I can around cultural safety, cultural humility, co-facilitating workshops on cultural safety and humility, purchasing books. I highly recommend Richard Wagamese's One Drum. There's also Held by the Land, which is an author from Squamish. And supporting Indigenous people and businesses. So whenever I can, if I have a choice where I have to buy something for myself, I will choose, if I can, to buy it from an Indigenous seller as opposed to a more common business. And what do I mean by being in relation? That means all of my interactions are framed from coming with an open heart and an open mind. And I have to try to practice humility to be able to do that. I have to be open. I have to have my heart open. Everything comes from that space. It's not a cognitive thing. It's not an intellectual thing. It's an emotional. So the second step was, before I even could implement some research, I first had to do community engagement, or what was termed stakeholder consultation. And that was to start building those relations, right? I came from having been abroad. I started from scratch in my faculty position at the beginning. And I had to figure out, well, how do I build these relations? And thankfully, I had advice and guidance from a Métis individual who's very well respected, Professor Jeff Redding. And he had the links to First Nations Health Authority, which then had the links to community. And they helped invite elders and knowledge holders to what was called a drumming talking circle. To help me with that process, because I was very new, I actually hired an Indigenous co-facilitator. I made sure that all of the catering that was provided was from an Indigenous caterer. All of the activities, so we had 2 talking drumming circles. I hired venues and I went to Indigenous spaces. So previous speakers talked about space, physical space or place. I made sure that the research or the engagement was done in a safe space, in an Indigenous space. I didn't ask elders to come out to UBC out in the middle of the side of our physical land here. I went to where it was appropriate for them. And then eventually we wrote a report that I consulted with elders and made sure that everyone was happy with how it was designed. I hired an Indigenous designer to produce that report. So one of the important pieces, again, is respecting culture and protocols. And that meant that each sharing circle was opened with an elder's blessing, because that is protocol. It also ended with a closing from an elder. Our physical format, as you can see from that picture, is we were in circle, which is a way of equalizing power. I wasn't at the front of the classroom. I wasn't at the front of people sitting in rows. Everyone was in circle together. And that is an Indigenous protocol and a way of knowing and being, for making sure that there is that practice of all things are equal. There was an emphasis on personal stories, and people shared stories, and that's how knowledge was gathered, was based on stories. So I have to say, when I started out, I didn't always get what was being said from a story, and I thought, oh gosh, I don't know where this is going. But I've since learned that there's real gems in the story, and that's where the information is, and it's a different way of communicating and gathering knowledge. And then, ensuring that people shared their language, and it was hard to write notes for language that was Coast Salish, but the communication was, language is the culture and the culture is the language. So that is a way of knowing, and people, even if they don't understand each other, they recognize that saying a word in your native language is an important practice, and it's important sharing. And it's a way of being in relation. It's not forcing people to speak a language that isn't theirs. So another piece that is, I guess, an enactment, we actually practiced a teaching. And one of the members of this group was an elder, and she shared how to make rattles. So we had the material, I gathered the material. She taught, how do you make a rattle? We made the rattles each for ourselves. And that was not only a sharing of traditional knowledge, but it was an enactment of traditional knowledge. And then so people had that to take away with them. That was for their benefit as well. And I learned a lot in that process. And so this was the rattle that I produced for myself. And the heart at the bottom is, again, it's all the languages from all the women who were part of this initial stakeholder consultation. And these are for words of women. So these are the different language words for women, and it was in relation to heart health. So that was the second step, to be able to have an equitable partnership, and then writing a grant to do the research. And what came from that consultation was not the idea I had initially for the research. It was something else, and it was about foraging walks to promote Indigenous women's heart health. So 2 of my co-applicants were elders. We did win a CIHR Indigenous Gender and Wellness grant, but because of COVID, we had to put that on hold. The community had a number of passings and a lot of focus on how to deal with COVID. So even though we won the grant in sort of 2020, it was supposed to start in 2020, I just put the whole thing on hold out of respect for the community. And I just waited till I thought maybe things were a little bit in a better place before I then approached one of the elders, say, should we start this project now? In the meantime, I wanted to make sure that there was still a connection. So I reached out to the Leong Centre at Squamish Nation, and said, hey, there's this opportunity that UBC provides funding directly to community to support partnerships, new and old. What is it that you need to, what do you need to have done in your community where you could benefit from $1,500 or $1,500? And so because of COVID, people hadn't been taking care of their cedar baskets and their drums. And so I helped support the manager of the Elder Centre write the application for the benefit of the community, and they received that money directly. Again, that's very different than our structure, where usually it's the researcher, the academic, who gets the funds and then distributes them to community. This was a very different financial structure. The money went straight to community. Also, throughout this entire process, I worked very actively to honor elders through gift giving and through allyship, through practicing allyship. So I would send gifts to the 2 elders who were my co-applicants. Every year at Christmas, I would send them some cedar soaps, just as a way of honoring them. And I also made sure that the budget that we produced included an appropriate amount of honoraria for them in their capacity as guiding the whole process, and then in the individual kind of circle events that happened to make sure that the money was appropriate. And they told me what that fee should be. So finally, we were able to actually have the project. It did take quite a while because first I had to get permission to use the land. Initially, the idea was maybe we would hold the work, which was again in circle, on the territory of Squamish. But because of COVID, we had to focus everything on Zoom-based virtual spaces. But in the meantime, I had gone through the process of getting land approval and also getting approval from Squamish First Nation Council. And that involved a number of meetings, a number of presentations before I finally was given the opportunity to speak to the council. And then they gave approval of the project, which then allowed me to write a research agreement. So what was meant to be a 1-year project ended up being a 3-year project. Thankfully, the Squamish community communications helped sort of support recruitment and advertising, and all of the work was grounded in Indigenous wisdom, culture, experiences, and knowledge systems. So again, we had elder blessings and closings for all 8 of our sharing circles whenever it was possible, whenever they were able to attend. Again, the format of the research was as a sharing circle, and it was all based on storytelling. Because it was virtual, we couldn't share a meal together, so I made sure that each participant who attended the circle received a catered meal directly to their home from the same Indigenous caterer I had used before. So there was a lot of coordinating involved to make sure that we got what they wanted from the menu and that it arrived on time. And again, appropriate levels of compensation for time. And each stage of all of this involved checking in with elders, getting their advice, confirming the interview guide or the sharing circle guide, confirming what stage to approach for the council, how to approach the council, what the agendas should be. So every single piece of the work from the very beginning and even before the beginning was informed by elders, which was premised on that initial relationship building. And because schedules were tricky at some point over the summer, we had to split our sharing circles. So we had to duplicate that to accommodate mixed availability. Through the process, after the first couple of circles, a number of participants wanted to actually go out onto land and learn about plants and learn about the health benefits. So we pivoted and we actually had a land-based activity that wasn't initially planned in the grant. And then I think the biggest piece that I'm probably most proud of, and I'll show you on the next slide, is through all of the stories and through learning about the different available books, we put together a deck of 43 flashcards with the name of the plant in both Squamish and English language, an image of the plant, and on the back of it, information like how it benefits your health, how do you use it, where do you find it, what time of year do you forage it. And so that was for practical use and community benefit, and that was our major output. And an elder said that at the end, we should have a drumming in ceremony so that before sharing and disseminating these cards, they were blessed through a formal ceremonial process to make sure that it would be received in a good way by members of the community. So these were the cards. So I hired a Squamish Nation artist to design that initial image of a number of women foraging out in the forest. And the plant that you see, I know it's a bit small, but the big leaves are Devil's Club, because there was a lot of focus on Devil's Club. And we thanked on the back of that card, Haichka means thank you. It also kind of means welcome in Coast Salish language. We had some key cards, and this is an example of one of the cards. So this is Devil's Club. The reason it has a bit of a red around the outside is because there was a warning around needing caution for this particular plant. And we had about 43 of these. And eventually, after all of this process, we together wrote a paper, and I included all the members who wanted to be on this paper. And it was very interesting because the journal, of course, wanted to know what everyone's title was, and they automatically send messages to everyone saying, "Dear Dr. So-and-so," which was a bit offensive to some of the members because they were elders. And I had to sort of explain this, unfortunately, is a bit automatic, but I was able to, at the proof stage, to make sure I said elder or knowledge keeper, and that was their title. It wasn't a PhD, it wasn't an MSc, it was elder. So we need to change our journals to make sure that we can integrate appropriate cultural words and roles that reflect that way of being and way of knowing. So just some recap of what I've covered. There's the 7 grandfather teachings, which is common to the Anishinaabe. There's probably other teachings for other groups like Inuit, Métis, and other First Nations across Canada. But this is their guideline on how to live well and how to live in good relations with each other. And each of those 7 teachings need to be balanced. And they include different values that we don't normally think about in our Western research and ethical frameworks. There are the OCAP principles and the TCPS2 that both recognize the specificity and sovereignty of each community and the importance of specific components that we don't normally think about, like councils, elders, protocols, etc. And there's 4 sort of interrelated foundations of trust for engaging, respectful relationships, relevance, reciprocity, and responsibility. And hopefully with the example I provided, it gave you a bit of insight on like the extent of what that means in practice and the length of time that it takes to make sure that you work in a good way with an open heart and an open mind. Thank you.
Thank you so much. I'd like to thank all of our panelists for wonderful, wonderful presentations today. At this time, I'd like to ask if anyone has any questions to either raise their virtual hand. You're also welcome to leave your questions in the chat for our speakers, and we'll certainly make sure to bring them to their attention. Oh, perfect. Go ahead, Catherine.
Hi, can you hear me?
Yes.
Perfect. Thank you so much to all the speakers. I have lots of compliments and reflections that we don't have time to share, so I'll just put a blanket thank you for all of the inspiring things. My question is probably best suited for the second group of panelists, but obviously anyone can answer. I guess this is a little bit of an ethical issue that I experienced in engagement of patient partners, specifically youth patient partners in qualitative research. And I had all these safeguards in my work to protect the participants and the mental health and the potential repercussions of what we talked about in the interviews with my participants. And that was all very much with the help of Research Ethics Board. But my question is, how do you support patient partners with the potential emotional repercussions, personal repercussions of engaging in research? In my situation, I had 2 young people with a pediatric chronic neurological disease that were reading about other people, and parts of it got quite emotional. Fortunately, I had good rapport with them. And because we were kind of friends at this point, we were able to manage it. But I realized in retrospect, I had no plan or preparation for how I could manage that situation. So I was wondering about any of your advice in that front.
I think that it was directed at Manveer and I. Was that the second group of panels? It's a really great question. I mean, I reflect on, what we had planned for our focus groups. And I mean, I can resonate also with like the difficulty and then knowing that the focus group discussion took place in Punjabi. So a lot of the time I didn't really know what was going on, to be honest with you. But you could read people's emotions. Particularly, this was very striking in the mother. We had mothers, fathers, and grandmothers that we interviewed. And I didn't sit through the fathers ones, but the mothers and grandmothers. And I remember distinctly, there was a woman who, got had a very emotional story. Others others that were participating were, had tears in their eyes. And we did have a social worker present in case, and we let people know that that person was there, if they wanted to, have a conversation with them. I think what and this was just an observation, Manveer, free flow to chime in. But I think because we did it in Brampton in community, I think there were a lot of conversations that happened, in the parking lot after that I witnessed, and in other spaces like on the side at the coffee break. And what I got from that was that people were supporting each other through the conversations, and I think culturally competent, relevant conversations they were having with each other about a community issue. So that would be, I guess I was fortunate. I can't say we did that intentionally with knowing that would happen, but I think that was the structure we set up, and hopefully that was a supportive enough environment that people could leverage while they were in that space. Manveer, do you have anything to add?
Yeah, no, that's great to see. The only thing I'll add is I think just organically a lot of the way that the community came out, like just being supportive, being collective. And that was very evident throughout the focus groups that people were consoling each other and supportive. And I think even for me, as I said, it was, it felt lots of different things because I'm from that community. I've experienced it being in those focus groups. But I never felt like othered or outed or anything like that, despite being on the research team. So I think the essence of the community really, really came through for our work, particularly. I don't know if that's the case always, but yeah.
Yeah, Catherine, I don't know if that would be the case given your the structure of your setting.
I think what's helpful to hear is that these things happen organically. I guess for me, it's still, I also feel like, did I do my patient partners a disservice by not adequately preparing them or setting their expectations that this could happen? I did say the things that we talk about maybe bring up some emotions, but because they were so enthusiastic to participate, I don't know if they were really prepared for how much reading these interviews and participating in this research will impact them. Again, fortunately, I don't think harm was done, but I could foresee situations where engaging patient partners as a research member may cause harm that we don't have the resources for. For participants, usually we send them back to their physician, or we have a mental health support in place or something like that. So, but it's good to hear that it seems to happen organically.
Yeah, and I mean, I think that you're open to accepting feedback about that, and obviously you would do whatever you could to support them within the context of your resources that you had available. You wouldn't just leave people leave people out to dry. So I think that's where the harm really happens. So you had an open line of communication, it sounds like, with your participant. So
I'd like to open up the conversation to our two other presenters as well. Ambreen, would you like to go first?
Sure. I love your question, Catherine. It's such an important one, and it's one that sometimes also becomes a barrier to kind of doing this work, right? When the fears become so elevated that you might do harm. I think some of the ways in which we've tried to approach this, in particular, is using a trauma-informed approach. So taking time to understand what are the systemic and structural issues related to whatever topic or illness or geographic region, doing that kind of homework, and then kind of the degree of violence that's been imposed on people kind of matches the degree of relationship building that needs to happen before we can engage in conversation. I think some of the other things that have really helped me personally are thinking about pathways to change, which was so crucial in the way we did our work. People are more open and to their own vulnerabilities as well in those situations when there is a clear pathway to change. Like I'm part of this project because this change is going to happen because of my involvement. So articulating that clearly and closing the loop on that with them. So you were involved. This was the change that we thought could happen. This is the change that has happened. And this is where we can go next or cannot go next. And that kind of transparency and communication is key. I think the other piece is also ask community. Sometimes, and I've heard patient partners tell me, we don't want all the data. Like, could you just give us a PowerPoint with higher themes so we don't need to get into it? So sometimes asking people like, this could be a lot. This could be a bit triggering. This is a lot of information. How would you like to receive it? And some will say, oh, I want everything. And others will be like, but actually, could you just summarize it for us and we can do feedback? So ask.
Excellent response and advice to consider. And Elaine, did you want to go next? I see your hand raised.
Yeah, I just wanted to add to that. So I guess drawing on what I just shared about Indigenous communities is they determine the level of engagement. So I think it's important to have had maybe a partnership agreement with your patient partners to establish, like, do they want to have data? Do they want to be involved in that process? And that agreement would also include what is their responsibility to care for themselves in the instance of a trigger and your own, right? If it's a really personal piece, researchers need to care for themselves as well. And we need to make sure we have our own resources for our mental health. So I think the same applies to the patient partners, and working that out in an agreement is really important and I mean, normally for ethics, you would have had to have, a counselor or a resource to a counselor. But when they're very active and fully partnered, I think an agreement would be the thing that would flesh that out beforehand. But I also agree with the previous panelists that in some ways community is there. So in the context of the work I had, elders served that role as well, that they were there for wellness in case other community members were, felt really upset about experiences they had with the healthcare system for their heart health. And they were there in that role as well and in that capacity. And that was communicated. So those are my additional thoughts.
Well, I'm cognizant of time. I'm sure those who may have additional questions for our speakers today can certainly directly reach out to you with additional questions they may have with respect to your work and the spaces in which you work. I'll pass things off to Kim for final remarks.
Yes, thanks so much, Priscilla. Thank you to Priscilla for doing so much work organizing this. It's been great. And thanks again to all of our panel speakers for just really insightful and helpful talks, and to everybody for attending. And also just a reminder that this is the last Trainee Hub event for this year, and we'll resume again in January. And then also just a note that there is a link to complete a survey just to give some feedback and input on the event to help inform future events that you can fill out. And that link will also be sent out in an email with the recording. So with that, I wish everybody a happy holiday season, a restful holiday season up ahead. And thanks again to everybody for joining.
Thanks very much. Bye now.